It is 7 a.m., folks. Let's come to order. It's the Board of Health. Do we have any members of the public in the room with us today? Any online who would like to share their thoughts with the board this morning? Hearing none. Ask for a motion to approve last month's minutes.
So moved.
Second. Second. Any comments or changes?
Well done.
Hearing none. All in favor?
Aye.
Opposed, same sign. Motion passed. Forte.
All right, good morning, everyone. Happy March. Almost April. Our general update. Last week, we had the opportunity to join the Montana Primary Care Association up in Helena for a day of advocacy and policy writing. We actually had the opportunity to meet with some local legislators, get some amendments added to some bills, and get some work done. So it was a good visit in Helena. You can see our group there along with our RiverStone group in the report. One ask of everybody on the board today, before you go to bed, please call the switchboard and ask the governor or just tell the governor how important House Bill 245, Medicaid bill, is to you. And this can be a simple message. Just please thank the governor in advance for signing HB 245. Montanans want to keep access to their Medicaid. So,
And I thought it was really good to have that in the agenda because I already did it.
good. Thank you. And so there's a ongoing last ditch effort by folks to phone bank and ask the governor to veto the bill. But all signs point to Medicaid continuing here in the state of Montana. We'll see what the federal government has to say about that coming up. We also wanted you to save the date, Tuesday, April 22nd, 11:30 to 1 p.m. And in my best, Mike Nelson at the fabulous Northern Hotel in beautiful downtown Billings. We will meet for lunch, camaraderie, honor our volunteers of the year, and just have a chance to get together. So as volunteers on this board, you are all welcome. Again, April 22nd, and save the date is out in the mail. Also, just one point of admin. We had Dr. Dorothy Sizemore, our Montana Family Medicine residency faculty physician, doctor of osteopathic medicine, recognized in our 40 under 40 this year across the region. So congratulations to Dr. Sizemore. And then I'll follow up with one public health update and ask too. That's not here, but I will send it out to everybody on the board. We have a proposal and a new bill being heard in committee on Monday, 8 a.m. It'll be in business and labor. And this is to adjust licensed establishment fees across the state of Montana. Currently, 75% of those fees are funded by local property taxes, increasing the tax burden on county government, but also individual taxpayers. And these fees have not been adjusted or increased for over 15 years, since 2009. And so we have a fair, balanced and fair proposal up on the Hill in Helena to increase some of the licensing fees. That will allow us, as the environmental health sanitarian entity that inspects pools, hotels, restaurants, etc., to do so on a more consistent basis and give business owners more bang for their buck. And so if anybody has an interest in helping us support this licensing fee change, it'll be heard on Monday at 8 a.m. In the Business and Labor Committee, and support your local sanitarian.
What did you say it was?
The bill number escapes me at the moment, but I can grab it real quick unless Eric has it on the top of his head.
Senator House.
It is, I'm gonna pull it up for you. That's a good question. There it is. It's House Bill 853. House Bill 853.
So it'll be on the Senate.
It'll be in House Business and Labor.
Should have already passed.
No, it's a new, it was a revenue bill.
Number again?
Yeah. What's that?
Number again.
House Bill 853. Up for discussion at Business and Labor.
Will you make life easy for us and send us the number to call?
This one's not a call, it's a testimony. So once we get there, we can make calls and support if it passes out of committee. Getting back to the written report. Wanted to congratulate our own Nicole Lund. Nikki was awarded the McGarrett Children's Champion Award by the Children's Alliance of Montana. Nikki's our current Child Advocacy Center coordinator, and this award recognizes her outstanding accomplishments working on behalf of victims of child maltreatment across the state. We're proud to update our UBS numbers this month and this year. Last year, we connected almost 700 new patients to care at our community health center, resulting in a unique patient population of just over 14,400 patients who completed over 70,500 visits, compared to a unique patient population of just under 14,000 last year, 13,711, and only 65,000 patient visits. So we continue to grow, and we continue to demonstrate the vital need for affordable healthcare across the community. We're also looking to expand our healthcare for the homeless reach and healthcare programs out there for folks that don't have a medical home. And so we're looking at proposals from the Montana Rescue Mission. We're looking at proposals from the Downtown Business Alliance, looking to expand our homeless services and reach across this community and provide additional services to folks who are unhoused. We have now posted our behavioral health systems improvement specialist. That'll be our new crisis diversion coalition coordinator, as well as the herder of cats in general, and getting folks on board across the community so that we're all moving in the same direction across the continuum of behavioral health care, from prevention to treatment to diversion and crisis, etc. And so if you know anybody who could be interested and is an excellent coalition builder, please have them apply. We're hosting our annual free children's screening clinic again. It'll be Saturday, April 5th at the clinic from 9 a.m. to noon. And so this is our Shriners Clinic, partnered with Shriners Hospital for Children, that provide screenings for numerous physical, neurological, and developmental disabilities. We continue making progress with our new mobile health unit. I wanted to share the photo there. It's been well received by folks and other groups across the community that I've had the chance to speak with. And so we're excited to get that coming to us, still on schedule for April. So stand by to see that out in the community at a school or community center near you. Also proud to announce our new family medicine residency class for 2028, our class of 2028. Our intern class that'll start this summer was selected last week during match week. And so you'll see them soon. Important to note that United across this country, family med programs saw a lower fill rate this year, filling only 85% of their positions across the country in the match. By contrast, internal med programs, like we have up the street, saw a fill rate of almost 97%. So we continue to struggle to get medical students interested in pursuing family medicine careers.
So did we get a student from Ukraine?
We have a potential student who'll be joining us.
Megan said yes.
From
I think-
Ukraine, yeah.
Yeah, I think we have one of the residents. I don't know if she is a student from the Ukraine, but she did medical school.
Did medical.
Yeah.
She did medical school in Odessa. Yep.
I thought that was cool.
Yeah. So you talk about resilience. She was in medical school as the war began and came to the United States to finish and will now be a resident in our program. So got a great group of residents this year. And we have one returning. We have one resident who will be returning after a short personal leave of absence. So it'll be good to have a good diverse classes here from different perspectives from across the country. And it's incredible where folks actually came from and across the world now. Wanted to remind folks that the Behavioral Health Heads Up Camp is still open for applications, as well as the AHEC Med Start Camp. If you've got students who are in high school interested in medical careers, those camps are still open and accepting applications. We talked a little bit about the employee engagement survey last month, so I just wanted to give everybody the update in the report. You can see the numbers. I'm not going to go through them individually right now, but out of 36 measures, 80% scored highly favorable, and the strongest scores showed that most of our staff, 95%, the overwhelming majority, are proud to work here at RiverStone Health. They know what's expected of them, and the mission purpose of our organization makes them feel like their job is important. So those were all great measures to see on the survey. The Live Well Center Gym is now open for employee use at no cost. So another great employee benefit that we can offer to staff. So we've opened that gym. We're also working through ways to make our food safety inspection reports readily available to the public. And so in keeping with the theme this morning, license and inspection rates, giving kudos to our sanitarians and environmental health staff, your voice is needed, that of this board and the public. And should you feel so inclined to go to riverstonehealth.org/food survey, you can take a survey on your own perspectives on what you'd like to see us implement across the restaurant inspection work that we do here at RiverStone Health. And so trying to be more transparent about inspection results, make them more user-friendly, both to business and to the consumer. So please take a look at that survey if you will. Getting into public health. Over the last couple weeks, we saw a decrease in flu. So we have reached our peak, it appears, and we're on the downward trend in terms of influenza. The influenza A, right, Megan? A has been the predominant strain this season. And so it has been particularly sticky and long lasting compared to previous seasons. And so we've had a rough flu season, but you can see that downward trend. We've had a couple increases in COVID-19 across the state. These are statewide numbers, not local numbers. So it continues to be something we need to look at and watch for. And we will get into a more in-depth conversation on measles and our measles preparedness. But at this time, it's well over 400 reported cases across the country, across 18 states. There have been 3 more localized outbreaks of the measles within the United States, and now up to 2 reported deaths as of March of last week. You can see the case demographics there. The majority of measles cases are in our younger population. And the majority of that younger population has been unvaccinated. And so, go ahead.
So the kids who are vaccinated and still get measles, do they get a milder case?
There are very, very few, less than 1% or 2%, that have gotten measles and been fully vaccinated.
Yeah, so to me, the
But we're gonna have a
argument
whole
against the
conversation. We're gonna have a
anti-vaxxers
whole,
is it may not prevent it, but it really saves the kid.
we're gonna have a whole conversation on measles towards the end of the meeting. And I'll go give Megan some time to prepare. So 95% of cases were unvaccinated across all age groups. But yes, the vaccine is highly safe, proven safe, highly effective, and 97% effective at preventing measles. And so, again, while it's not going to ensure with 100% certainty that you won't get measles, it is going to protect you, your family, and most importantly, the community, if you're vaccinated. So that's the best defense against a measles outbreak in this community. And so much more on measles to come later in the meeting. Bird flu remains, but the latest CDC update was provided last month. And so I provided that latest information to you at last month's meeting. Any additional questions from the report or comments?
I will second John's request about the call to the governor's office. RiverStone's business, Bean Counter looks at the income statement. It's about half patient care, biggest piece of patient care, Medicaid. When expansion was first passed, I remember with the committee swagging the annual impact of being $2 million a year. And I know when we looked back on it, that underestimated. So you go through that thought process that we're now 8 or so years out into the future from that date. And population has grown and there has been inflation. And the number will be bigger than 3 million if we lose expansion. Could be bigger than 3 million if we lose expansion. So it's back when I did my first CFO job, I learned the acronym AFDC. It was something, at least in the California regs where I was working, where the law passed for Medicaid defined A as age, F as female, D is disabled. It's where most of the disabled people get their medical coverage. I have family experience with that. And C is for children. So men were excluded. Big thing that expansion did was bring men into the last number I've heard for the Medicaid population is that 85% of them are employed. Don't know what portion is disabled, which is not working. Vast majority of Medicaid beneficiaries are employed, simply work in lower paying jobs that don't provide health insurance. Any other comments or questions? Hope you can take calls.
I just add to echo that on a federal level now, the conversation will be around CMS, Medicare, and Medicaid. And I'm reading a stat article this morning that the title was "Nobody Knew Medicaid Could Be So Complicated." And the House plan to cut government spending included Medicaid. It was hitting snags because folks in Washington are realizing that it's going to be very difficult to adjust these programs that so many Americans rely on across all parties, across all locations in this country. And so what becomes a really easy talking point is now going to become more difficult to create policy. So nobody's saying we don't have to get rid of any potential fraud, waste, and abuse. We need to, but we've got to do it the right way. And so the last thing I'll mention is we had a good conversation, just another federal update. And this will take away from my policy committee update. We had a good conversation this week with Tom Engels, the HRSA administrator, new HRSA administrator in Washington, D.C., and just echoed his support and the department's support for community health centers across the country, and how we will be able to leverage and embrace this, the new Make America Healthy Again movement, or MAHA, as we focus on chronic disease, as we focus on food insecurity and healthy eating. We are a part of that solution in community health centers, and they recognize that. And so we're going to leverage that to our benefit.
Any other comments? Hearing none. Megan, you're up.
So my report is in the packet. As far as recruitment is concerned, we have one pending offer to a faculty position. And we have one, Dr. Funkin is leaving, and we have another faculty member who we also know is leaving this summer, but her resignation has not been completely formalized yet. We are continuing to recruit APPs, continuing, we have an upcoming meeting planned to talk about the APP training program. We kind of touched base about our residency class, which we're really excited to have, but we did not match in the first round of the match, and had to go through the SOAP process to secure our 9 residents. So whenever that happens, I think part of it is what John alluded to, is that family medicine match was just down across the country. And I think that part of it was related to that. I also think that, this year, the majority of our interviews were virtual. And I think virtual interviews really hurt us. I think it helped get people here to meet people, meet the residents, meet the faculty, see the community. And I think it's really hard to get a good feel of that virtually. And so I think that hurt us as well. But we always send out a post-match survey to try and gain some insight into what we can do to improve the process for the upcoming year. We also just had, this has been a really difficult year for our faculty group and our residency. We have had a number of family tragedies in our residency class that they have had to cover. We had, Dr. Brand, as all of you know, had his daughter going through cancer treatment during the interview process. And so I think that the residency interview process kind of started after we were all settling from the big rift that happened over the end of the previous year, fiscal year. And so I think that we just weren't going into the interview process from the strongest place that we have done in the past. So either way, we have had classes in the past that we have not matched in the first round and have secured those spots through the secondary match process, and they have turned out to be some of our greatest classes. And so I think we're all just really eager and excited going into this next year to sort of see what this new group of residents will bring to the residency. The other, we're continuing to really, one of the big needs in the community is really in the mental health realm, particularly pediatric mental health. We, both with the mobile clinic and with some of the other projects, I sort of talked a little bit about the AWARE grant that we had going with School District 2. I think we're really looking at that as an area of potential expansion. I think that regardless of what happens with Medicaid, we are likely to have Medicaid coverage for children. Even if expanded Medicaid goes away, that's unlikely to affect a lot of the children we have on Medicaid. So I think that that is sort of a safe area for us to be looking at expansion. Measles, I talked about measles in there. We'll talk more about that later. I did include, there's a request at the last meeting to include some information about how to have conversations about vaccination with people who are vaccine hesitant. We included some of that information in the packet. There's a really good handout that is written towards the public from the World Health Organization, and we included that in there. There are a couple of other resources, reliable sources of immunizations information that we've given out previously. I didn't see that attached in the packet, but if it's not in the packet, we'll make sure. That was a late addition that I added yesterday, but we'll make sure that that information kind of gets out to you. And I think that that is pretty much it.
So Megan, being very old school, I had to look up what integrative medicine was. And it says it's traditional and alternative medicine.
Mhm.
Now, Wikipedia defines alternative medicine as any practice that aims to achieve the healing effects of medicine, despite lacking biologic plausibility, testability, repeatability, or evidence of effectiveness. So what are we doing?
Yeah, so integrate. So I would not use Wikipedia as a resource. This is also what I sometimes share with people who are looking for vaccine information. No, but integrated medicine. So really, it's the concept of it's not just about allopathic medications. It's about not just vitamins and sort of alternative treatments, but really looking at all of the various aspects that promote health. And so it's talking about food as medicine. It's really focused on exercise prescription and looking at lifestyle, other lifestyle interventions, other ways to manage stress. So, you don't typically go to your physician and talk about mindfulness. In integrated medicine, there's a big focus on how are the ways that you manage stress? Have you considered mindfulness? Have you considered using a gratitude journal? Have you considered using yoga? So it's looking at sort of all of those other non-pharmaceutical interventions. We know that studies are very expensive to do, right? And so that's why the majority of the studies that we have done are through pharmaceutical trials, because that's where they have a lot of the money to spend to invest in those studies. And it's also difficult to get good data. I mean, we know it is really difficult to get good data on nutrition. Because it's really hard to conduct those evidence-based studies, really looking, it's hard to do a randomized controlled study on nutrition, right? And so integrated medicine includes all of those other things. It's not just, crystals and sound bowls. But if crystals and sound bowls are something that decreases someone's pain and doesn't, run them financially into the ground, then, I'm all for that. So Dr. Solomon has done additional training in that whole realm of alternative medicine, or not alternative, integrated medicine, and is starting to incorporate. And we have a resident who's also very interested in that. And we're doing a journal club because we do aim, there is evidence out there on a number of these different treatments, magnesium. The advantage of magnesium in sleep and anxiety and managing stress. So that's what we're doing.
All that makes sense, and I'm glad we're doing it. Thank you.
Any other
We'll
questions?
start our crystal shop soon. That's how we're going to make up the lapse of money that we have from Medicaid, is we're going to sell crystals and sound bowls.
Go for about 5 million. up here.
Big business.
Just a comment, and we passed on the new members of our community, the refugee program, and that's all established. That we don't have any more coming in.
The what?
The refugees. So, pardon me?
That program is on hold. There are no more refugees that are coming into the community right now, but we're continuing to care for the refugees who have been placed here. But I think nationally, that program is really on hold.
Which is kind of the comment that I wanted to make. Communities across the country that have everything was done in regards to the resettlement, the housing, the education, the language studies, all of it was done, and persons were ready to get on planes, and it was stopped in its entirety across the country. Rather disturbing. And individuals that had been for years been vetted, that had worked for the U.S. government essentially, and had gone through exhaustive vetting processes, and they would stop. Just a comment. I get to comment on things other than immunization. That's all.
Other comments? Hearing none, Spencer, you're up.
Right. Well, first off, I'd like to think Shannon did a really good job detailing the specifics of our finance committee. Find that on page 22. And in the way of my predecessor, Jim, we're going to skip over the balance sheet. We're going to come back to that. We're going to have a larger discussion about cash and some of our, giving the management team some objectives as they start preparing the budget going forward. So if we're looking at the statement of revenues and expenditures, you'll see, I'll focus on year-to-date information, but year-to-date, the organization revenues totaling $37 million. And we're seeing better performance in Medicaid and insurance than we forecasted. Both of those, I think the Medicaid piece is roughly on par where we were last year. And we've seen an uptick on the insurance side. If you look down below, the operating expenditures remain below budget year-to-date and month-to-date. So that's another positive sign. Operating expenditures during the month or for the year-to-date were $34,391,000. So if you look at that comparative to last year at the same time, we were at $36.6 million. So I think that just highlights the amount of effort and work the organization has undertaken to save money and to meet its objectives. The other thing I wanted to point out on the statement of revenue that we have seen is that we are performing well from a budget standpoint. 37 million are in revenue compared to 35 million budgeted. So an overall improvement or overall projected or improvement over projections of 1.9 million. That's remarkable.
And is that on the expense side? We're saving on expense that we're 2 million to the good, or?
Correct. Over the previous year, and then 1.3 million over improvement over budget. So both very significant improvement. So now with that being said, let's flip back one page to the balance sheet, and we'll focus primarily this time on cash. Categorically, things remain very consistent. The organization, there's no big swings in any single area. So, but the discussion around cash is something we've had over the last few months. But cash at the end of the period was 11 million. Of that, 7 million is unrestricted. You see that comparative to 6/30/2022 to that fiscal year end, previous fiscal year end. So a remarkable improvement overall. If you now we're going to do another Jim move. We're going to flip all the way to the back of the financial package with where there are two charts. So hopefully you guys can keep pace, but it's, there's two charts there. The top chart, or the first chart, is RiverStone's unrestricted cash balances. And you can see from that metric, and Shanna's slid in a little bit of a taste of what February was going to look like. So I think that's just to whet your appetite for next month. But February's information is included. That's why you see a little bit of an uptick after 131. But our overall cash balances, and we intentionally put a comparative chart that is over 10 years long, just because we wanted to show the history of the organization. You can see the cash balances are where they currently reside. Unrestricted are consistent with where we've been, a long time ago. I think the real telling chart is the next chart, which is the days cash on hand. And to Jim's earlier point about inflation and the cost of doing business is just significantly changed over that same period of time. You can see that the days cash on hand, we were trending very low, since the pandemic, and are now seeing a modest increase. And so we think actually not just a modest increase, a good increase, a remarkable and a commendable increase. So we're now sitting at about 45 days of cash on hand. I think Shanna mentioned in her notes that that's a significant improvement. I think we were at 33 days cash on hand at the end of fiscal year 2024. So an improvement of 12 days through January, and then even more, and another improvement we'll see when the February numbers are reviewed next month. But anyway, I think that's important to acknowledge. Probably I would say the level of our ability to save cash this year has been remarkable. That's likely unsustainable as we look forward over the next few years. Just with the state of the world, with Medicaid and all the different federal grants that the organization counts on, that's not likely that we're going to be able to sustain the same level of cash over the next few years. But we did want to give the organization an objective to achieve, to build into their budgets as they look forward. So, I think we all feel like we'll probably increase our cash on hand somewhere in the neighborhood of 20 days over the course of this last calendar year. Looking forward, I think we're going to, and Jim can step in here if he has anything to add, but over the next 2 calendar years, we were going to give them the objective to save another 20 days. So essentially have what we were able to achieve this year with the significant cuts and the staff reductions and everything. But so I guess that we are going to propose and ask for a vote on giving them some direction to meet that objective of saving 10 days on average over the next 2 years, or a total of 20 days as they build out their budgets. So, any questions on the financials, Jim? Anything you'd like to add?
Is everybody comfortable with the thought process of days cash on hand?
What is the reason we reduce the allowance for billing adjustments and bad debts?
It just correlates with the amount of receivable we have, so it fluctuates each month based on the aging of those receivables. So we reserve for anything 90 days past due at 100%. We assume that we're not going to collect any of those amounts, so it just really depends on the trend in our accounts receivable aging.
And what are 340B pharmaceuticals?
So those are essentially drugs, Eric can chime into, that we receive at a discount, very discounted rates, like pennies on the dollar for our patients, our clinic patients, for pharmaceuticals. And so as it relates to budget, that's another thing that we're navigating. That's a big revenue generator for our organization to the tune of about $2 million. We're seeing some changes within that, essentially a decrease in reimbursement for 10 of the highest performing drugs, and also a corresponding increase in the cost of those drugs, probably to the tune of $600,000 to $700,000 impact for us organizationally. Anything else you want to add about?
So is that federal reimbursement? Okay. And then the discount we receive from the manufacturer?
The drugs are kind of cheaper. Yeah.
So it's not federal reimbursement. In Montana, actually, we don't use 340B drugs for our Medicaid patients. We use Medicare I mean, it's billed to insurance. So the basic idea premise of the 340B program is that not-for-profit healthcare providers can purchase drugs at a reduced rate, but then you bill them to the insurance companies at what their reimbursement rate is, and you're able to keep the difference in the profits. So where you say you might usually get a drug at a usual and customary purchase rate of $10, and then you can only get $15 for that drug from the insurance company when you dispense it. 340B, you can get that drug for a penny, and then you charge the insurance company $15, same as if you had purchased it in its average purchase price. Does that that's the simplest, that's a very simple way of saying that.
Okay. You have to qualify for 340B coverage. It's based upon an uninsured or underinsured population. So if you're in Manhattan, it's a lot harder to get 340B coverage to cover that when you're in rural Montana. That they want to make sure that healthcare operators can continue to function and provide the pharmaceuticals to its patients. And so they provide those incentives. Okay, so how did we end up 172,000 over budget? I mean, if we're buying it for a penny and our reimbursement is 15, so that's $14.99. I mean, and I don't know what your scale is, but how do we end up 172,000?
Volume, an increase in volume, so filling more scripts.
But then we should have a corresponding increase in revenue.
We did, we had
Okay.
an increase in expense and revenue, but the revenue is outpacing the expense.
And so what that does, Mark, is it allows us to, if we have somebody coming in and who doesn't have insurance or they're a cash pay patient, we're able to give them, discount on those drugs or, slide the fee down on those meds so that they can afford their insulin or afford their cancer treatment or whatever that medication might be. It doesn't typically be way out of reach and super expensive. It allows us to provide them access to that therapy and to that medication. And then the money that we get back, the mandate within the 340B program is that money to go directly into providing care and services. And so use that money that we get in from that program to make sure that the clinic has the staff that needs to see all the patients, or we are able to provide care coordination or an innovative diabetes education program or something of the sort. We put that money back in the organization so that we can better serve those folks that need the care.
Any other questions about the statements before we call back to Days Cash? Michael?
Comment on days cash.
Okay. Go ahead.
Do it now. When I looked at this chart on days cash on hand by month, it goes back 10 years or so. That was very helpful for me to see that. And we're talking about now increasing that days in cash. Is there any way of figuring out what caused that almost 10-year decline in cash on hand? And I'm going to try to fix this and get it better. What made it worse?
Patient volume.
Simple as that?
Yep, that was the bulk of it.
Increasing expenses too. I mean,
Yep.
obviously that as it became the reduction in force identified, like we had just increasing ongoing expenses, not just staff, but just the stuff we're seeing just in general as far as supplies and those sort of expenses. So both of those things combined.
So get more patients. Easy peasy.
And, people were redirected into pandemic activities. And some of that staffing then needed to be adjusted with longer fighting the pandemic. Any other questions? Following up on Dave's or several decades in hospitals, I used to try to explain cash to people of Lionel Coach's background as being like the circulatory system, what keeps you alive. And that may be the worst analogy that anyone has ever made in the infinite history of the universe. Because I don't know clinical stuff, but you can't predict the future. Consumption of this stuff and consumption of cash change dramatically in short periods of time, as we've seen. You can see it in this chart. So to try to say, this is the amount that we want on the books is difficult. And from every area of the organization, there's competing demand for that cash. I harp on staff compensation since I have been on this board. Staff compensation. And that is one of the biggest. And we went into a budget. And we need to give finance staff, fiscal staff, targets, how we want the budget for next year prepared. And we need, in order to do that, it would help them tremendously if we can give them advice as to what we as a board would like to see in the budget as far as cash balances over the next couple of years. And if you look at this chart, you can understand the thought should probably be increasing. And what the absolute level this organization needs to carry, I don't know. None of us do. But we know it's more than what we have in the bank right now. So we want to take a chunk out of that and ask staff to, over the next couple of years, try to plan budgets together. Take those days cash on hand up another 20 days. Now, if they can't do it, they'll come back, 30 days from now, 60 days from now, they'll come back to finance committee and say it's not working. Here's the reasons. And finance will report back to this board. And ultimately this board will see the budget be approved or voted down. Does that help put this in perspective?
Thank you. This helps me tremendously. Tremendously. Thank you.
So Jim, I'd like to say kudos to the staff at RiverStone Health. You look from the pandemic, they nosedived and they're trying to climb out of that. And I can tell you from running the county, that is not an easy, you do any type of building project, remodel, you name it, unless you can get a fixed price contract. If they tell you it's going to cost $2 million, you better figure by the time you're done with it, you're into it for $4 million. This is an exceedingly, and just staff compensation, because you know what? If I'm not willing to pay you a fair wage, you're going to go over to John Forte's organization and John's going to pay you because he knows you're a good. So listen, it's not about hiring employees. It's hanging on to the good employees.
Retaining the best ones.
That's correct.
There is demand for the skill sets out there that we employ. And they will be cherry picked from us. That's smart.
Thank you. No, and just, super kudos to our fiscal staff, to Shannon, to Tyler, to our leadership team for being able to make some hard decisions, bringing to this board transparent information so that you can all help us make those decisions. Michael, I think what I was trying to think about what to say, because it's more than volume. It's more than just patient care. I think over the past 2 years, what I have been focused on is bringing this board information instead of what we think you want to see, information that you all need to see, and allowing you to make more prudent fiscal decisions based on the reality that we see on the ground versus just bringing you information to help us fill a need out in the community that we think we needed to chase. And the shift has really been from chasing things that will continue to help us spend money to chasing things that help us spend money where we need to fill a need in this community, but making smart decisions so that we're around for the next 50 years and can continue to serve this community. And so being better stewards of our mill levy funds and our revenue that we get from direct patient care, and trying to, Spencer's point, build a cash goal into this organization so that we can weather the storm. When we were at a place last year and needed to do a RIF, we had not set our organization up for success so that we could weather that Medicaid storm. That is what we have done over the past year. That's what this fiscal team has done, what our leadership team has been focused on across the organization is, creating the rainy day fund because we knew the rainy day was going to come. And so this will allow us to weather federal funding uncertainty, state funding uncertainty, just general uncertainty in the world that we live in 2025. So it's been great work by the entire team.
Michael.
I appreciate the process. Getting the board more engaged. And if we're going to be voting on something about that earlier, if we're going to be voting on something, it's nice to be able to understand much more precisely what we're doing. And I'm pleased that there is purposeful greater engagement of the board in terms of understanding and decision making. Thank you.
Other comments or questions? Start with financial statements then. Motion to approve finance committee notes. Approved. Second.
So moved.
All in favor? Opposed, same sign. It passes. The January 25 financial statements. A motion to approve, please.
So moved.
Second. All in favor? Aye. Opposed, same sign. It passes. And approve planning over the next 2 years to add 20 days cash on hand to the balance sheet. So by June 28th, a motion to approve.
So moved.
Second.
All in favor?
Aye.
Opposed, same sign. It passes. Thank you, everybody, very much, and for the discussion and the thoughts. It's greatly appreciated. All right, up next is Dr. Tapia.
Before beginning, I just wanted to make a correction on the minutes. It said that the meeting was called to order by John DOOR.
Actually, spell check.
Actually, it was me. Anyway.
You opened the meeting.
I was present. It's a tough group, and I think I was left off because I did fall asleep through part of the meeting, but I was there.
At least you were quiet.
There's some positives.
So at the meeting, we discussed two major areas. One was under organizational innovation projects, and we had asked for and received a report on some of the projects that had actually been completed or were close to completion, including the Joliet relocation, the school-based health center at senior high, employee surveys, and the new employee orientation with metrics and that sort of thing. And then the second thing we talked about had to do with the health center workforce standardization. And there's the slide deck is in the minutes here, but I guess at the health center, we have 177 not patients, 177 employees, staff over a wide range of areas, and trying to bring some kind of standardization to a group like that is not easy, because you have to have each one of them has a different set of skills that are required. But what we're trying to do is to make sure that a nurse at the clinic has the same skill set as a nurse at one of the outlying facilities as well. And so there's a timeline in there as to when checklists and cheat sheets, and we have spent some time talking about the difference between those two at the meeting, and that's ongoing. That was primarily it. I mean, there's a lot of detail in that, but how are we making it so that staff are flexible and have the required skill, and that that's being monitored and updated as it needs to be. So, any questions about that? Don?
So, I'm really impressed with all the reports we get, but they never seem to mention specific examples to give a demonstration of what they've done. They just said we did wonderful things, but I think more specifics would help.
Last staff to do that, although in there on the other side, we've got a lot of detail and specifics on the process that they're going through to enhance the peer review process, for example, or the competency.
But I was looking for changes made by what they learned.
At the outcome. Any other questions?
So do you have any type of program for employee performance? Do supervisors meet with their employees on once a year, twice a year, to basically say, I think you're doing what I expect of you, or
Performance evaluation sort of thing. Excuse me? A performance evaluation. Yeah, no, it is.
And that's currently ongoing.
Okay.
We call it our chats. And so we have our annual check-in process with staff for their performance evaluation. We've expanded that this year and are honing in specifically for our provider and resident staff with some new requirements that they have as part of the Teaching Health Center program. But we're also going to look at, as we evaluate market compensation across the organization this year, and try to budget in some of those increases to get folks closer to that market comp. A new merit-based, performance pay system and model too, that incorporates that feedback from the annual chat process. And it's really, how many questions, Jeff?
On the chat, there's
Yeah.
about seven.
Seven?
On the provider one, there's about 12 now.
Yeah.
so basically you have a beginning salary, a max salary.
We were at comp range, yeah.
Comp range.
Min, mid, max, right?
Right, yeah.
Yep.
And so then you, based on, if you meet expectations, you can move up a grade or whatever you call it on the matrix.
So that's where we're headed.
Oh, you're not there.
Right now, there is no merit performance-based pay, right? So that's where we're working towards, but we do have the performance evaluation process in place and have for many years. And that actually came out of a staff-led group, Leadership RiverStone. They had a project to do several years ago, and a group of staff from across the organization said, we need a better evaluation system.
Well, I think that's great. I mean, there's nothing wrong with it. I mean, if you don't tell an employee what you expect of them,
Right.
they have no way to get
Exactly.
to a goal.
Exactly. So it's done a lot to empower our managers and supervisory team to put some tools in their toolbox to have those conversations. Michael?
This committee Safety and Quality Committee has not yet seen the employee engagement thing that was done. I think we'll see it eventually at that
Yes.
committee and then here. But a summary of that was that there is very high scores of the employees and their relationship with their supervisors and the next level up. There's a tremendous amount of positive information there. So that's part of it. The other thing is this committee, we're getting a lot of information. The meetings are just, there's very little time to even talk about things because of all of the safety and quality initiatives that are taking place. There are a lot of them. Is that a fair statement, John? There's a lot going on in this committee.
But very little of it with patient care.
There's a lot going. I'll let it go at that. It's hard to summarize how much is going on. And somebody noted it in the comments at last meeting. There seems to be a lot going on in this committee, a lot of improvements. And that's an understatement of what's really taking place. I'm done.
About continuing education for the staff? Is that listed anywhere? Like for lunch and learning,
So not measured, but we'll talk about strategic planning next month. And that's just going to be a big target for us as we look at strategic planning going forward of how do we build out some of those career ladders for folks? How do we build out continuing ed opportunities and again, keep people here?
Yeah.
Because we're not ever going to be able to pay, what they're paying at the street or at other institutions. But how do we collaborate so that total compensation looks like our culture, our education, our mission, our actual pay, and those other opportunities for growth?
Are you talking about, like, say, for example, a checklist that, that they have this or that, if it's specific training,
as simple as triage or assessment skills, updating those as time changes.
Well, that's the specifics in the committee was the specifics where we didn't have a good process for onboarding MAs, RNs, LPNs within the clinic. And so they developed the checklist to make sure that we were, following Tulgawande's checklist manifesto, coach, and, putting what we read into action and developing a competency checklist for those staff so everybody knows what their expectations are.
Right.
One, so you're clear. And then two, everybody knows where some gaps could be so that we can educate and train and bring everybody to the same level of competency.
John, could I just
Please.
so briefly, I think this is one of the areas where the diversity of the different departments in our organization kind of comes out. So what I can say is that each of our departments has training programs that hit at different levels as it relates to the kind of specifics of the work they're doing. So, I think the short answer to maybe your question is, yes, we have like individual checklists that we do as, orientation and ongoing skills assessments. We do brown bags a lot. The clinic has kind of something that's similar to what you might call a grand rounds in a hospital setting. Every month they get up, somebody comes and does a presentation on a particular clinical topic. So it's really kind of departments in public health. They have an organized employee development plan that meets the needs of the public health staff and it meets the needs of their accreditation standards. I think that's the other thing to remember is that each of our departments is accredited by an organization that reflects and is for the work that they do. And almost all of those accreditation programs have some kind of training requirements for our staff to meet. A lot of the training that's kind of general in the clinic relates to HRSA requirements. So for example, HRSA requires all clinical staff to receive training on OB every year. We give them that training. So we hit at several different levels depending on the department.
Thank you. That's
And I think that's some of the,
QA, yeah.
that's some of the format change to that committee as well, is the recognition that public health is a little bit different than the clinic, that's a little bit different than home health and hospice, for example. So when that committee meets, if the topic is education, for example, each of those areas brings representation and talks about what their specific area is doing, what challenges that area has. And I think that's to Michael's point. It is now a waterfall of information, but we felt like it was really important to understand the different dynamics of each of those areas.
Other comments or questions? One other change to the minutes, Carrie, I just noticed my name is there as being present. I was not, and governance has not placed me as a member of this committee. I would like to attend if from time to time as a guest.
We should extend you an invitation.
I'll watch the mail anxiously. Okay. Motion to accept the meeting notes, please.
So moved.
Second. And all in favor?
Aye.
Opposed, same sign. Hearing none, it is passed. Mr. Crum.
Thank you, Mr. Chair.
Thank you.
Certain amount of repetition in the reports from this committee as we ongoing topic. The first one, which we always discuss, is the legislative update, which changes nationally and statewide, of course, daily. John, you've already talked about some of the things. Anything else that you want to add at this point?
In the notes, you'll see some information on Kratom that we talked about in the policy committee. There was a hearing this past week, or maybe it was last week, or no, it was this week, in Helena on Representative Nichols' bill to regulate Kratom within the state of Montana. Very good hearing. A lot of opposition to the bill as currently written, which we've been working with Representative Nichols directly on, because we need some changes. It is a industry-sponsored bill that provides light regulation. So it would be like the tobacco industry sponsoring a tobacco regulation bill. And so we are working with industry, we are working with public health, we are working with our legislators to help ensure that the right amendments get added into the bill, that we have some increased age requirements, bringing the regulatory age from 18 to 21 for purchase of Kratom substances, trying to ban and eliminate synthetic Kratom sales, which are currently overly potent, available at any C-store across the community, vape shops, town pumps, etc. And so trying to limit those sales and create safety metrics so that we have safe consumption and consumer education available at Kava and Kratom tea houses and other institutions across the state that are going to sell this. It is currently not regulated by the FDA nor listed as regarded as a safe substance. It is illegal to add it to any food at this point or beverage at this point, and should not be sold in licensed food establishments across the state. However, that is currently happening. Yet we don't have the regulatory authority to actually do anything about that. And so working with legislature and other state departments to determine the best way to move forward with regulation, lawmaking, and enforcement on kratom substances to keep the public safe.
We also discussed the increasing prevalence of kratom locally. I don't recall, is there some movement nationally also? Regard to legislation, seems to me I've read.
That's without the FDA taking any action, the federal government's not going to take any action. There are 8 to 10 states nationwide that have taken action, more that have implemented regulatory action, some that have outright banned the substance, other jurisdictions countywide or citywide that have banned the sale and use of the substance. And so we're waiting to see what the state of Montana's appetite is to help us regulate.
Then also the department is looking to increase public awareness of the quality of the various food service establishments in the city or the county, and developing some sort of rating system. And this, where that's at is now they're going to the providers to get feedback from them, see what their assessment is. Eventually, hopefully someone will be able to go to the website and see whether or not their favorite restaurant is, how well it's rated. And then we discussed the ongoing efforts to get information out to the public with regard to possible disease outbreaks, sort of informing and educating various institutions and areas of the public that need to be aware of potential outbreaks. The report from our committee.
Comments or questions for Brent or the committee or staff? Michael?
I'm really liking this idea of the restaurant, the quality, and when it's done, requiring big signs in the window of the door to walk in. And I'm even more interested in, I can't verify the accuracy of the data. I forget where I saw it or read it, but the overwhelming majority of gastrointestinal tract infections are contracted at restaurants, food establishments. I wish I had written it down and brought it to us, but it makes this initiative all the more important that the public can see the rating of this particular food establishment when it's in a big way.
We want to recognize those who are going above and beyond, who are meeting the requirements, who are taking care and take a serious investment in this community for providing safe access to food, clean water, clean beverage, and operate, award-winning establishments. We have so many of them across the county and this community, and we want to recognize them. And so by partnering with industry, how can we be a good economic partner? How can we share and educate the consumer that where they're going is safe and recognized as such? And so that's why this food safety survey is so important, to get that word out. But then too, the other part to this is how do we partner with industry to help them police their own industry? And there are about a dozen or so restaurants and food establishments across this community that are operating unlicensed without regulation from us. And there is a loophole in the state legislation that allows that to happen without enforcement. And so, how do we improve this monitoring and licensure system so that we can continue to hold folks accountable, but also recognize the incredible institutions that are out there for doing the right thing and providing a great service to the public.
Is there a way that this survey on social media, like there seems to be everybody?
I believe we have.
Okay.
I believe we have.
About 30 places,
Yeah.
there's always.
Yep. everybody's a critic.
So you're looking towards establishing some sort of an award, like a
So if you go to a major city across the country, or if you just go up to the Flathead and, or you go to Missoula or Bozeman, if you walk into a restaurant in any one of our other towns and cities across the state, you'll see either a smiley face or a letter grade, ABC, or, a happy, a neutral, or a frown. And so some sort of publicly facing placard that allows the user to know when they walk into that restaurant, a food establishment, that they have the confidence that, you know what, I feel safe and comfortable eating here. So states, many jurisdictions across Montana have already implemented this. So this is not something new that, we're trying to take the lead on. If you've been to Seattle or Denver or New York City, you've seen them there.
Is the posting usually required then, or is it optional? You mentioned.
So we're going to work on, the options at first and work with industry to say, again, we're not going to try to force feed requirements on anybody at this point. We want to have the conversation first. We want to gain buy-in, and then grow to, what do we want to see across the community?
Other questions? Hearing none, motion to accept the report. Second. All in favor?
Aye.
Opposed, same sign. It is accepted. All right. Executive Committee last month after our meeting. Way I think of exec committee is when the board meets the two primary responsibilities. Three. When the board needs to act quickly, when the staff needs a decision quickly from the board, and it would be problematic to get a quorum of us, the executive committee can act as the Board of Health. And the executive committee is the past chair, the current chair, the current vice chair, and the current secretary treasurer. And the second thing is executive committee prepares performance reviews of the CEO and brings them to this board for approval. So the third thing executive will do from time to time is to provide counsel, to provide advice to the CEO. When we want to handle something quickly and behind closed doors, frankly, get an expeditious conversation going with the CEO. So we met last month to go over a few things. We've all read about the pushback on DEI. We had things Jedi on our website, so that has been removed from our website. And we just need to be careful in how to communicate it. It doesn't change who we are. It doesn't change how we treat our staff. It doesn't change how we treat our patients. Okay. Second thing, I wanted to have a couple board members briefed on the finance committee discussion that we wanted to build cash organization. We get through part of that learning curve. And then third, a competing demand on the cash situation is the Colonial. The building here, the quasi pseudo apartment building down here. It really is, I believe, a risk to this campus. And opportunities to approach the owner came up. couple of months ago, Spencer and I had a quick conversation. Leaving the finance committee, we discussed it at finance. And we both just said it would be great to be able to take that thing out. So with the exec committee, we gave John some advice as to how we think that could be handled. And it has been absolutely unsuccessful. Okay, we are, you know, two people can look at the same thing and have completely different opinions of it, right? And I think his demand for payment is about 5 times what John's authorized by the executive committee to pay for the place. So right now, you're staying mom, and yes, there's a strategy behind that, but I don't want to go into details about it this morning.
Is there pending city action?
Yeah, is the city going to condemn that?
So there's pending legal action from the city. And there's pending legal action civilly, and that's all I'm at liberty to discuss.
Other questions? There is a method to our madness, trust me.
Madness to your
It just seems that if the city has any chance of proceeding, that's certainly going to greatly reduce the value of the property. And if they don't, the value is going to be more.
Well, the cat's out of the bag. Yep. Yes. There is more
Time is
pressure.
on our side.
If there's more pressure on the owner, he may find flexibility in his demands. Other comments or questions? Okay. We also had some time discussing KPIs for the staff. Governance will be meeting today after the board meeting and engaging in similar conversations about strategic planning and how we start incorporating KPIs into our operation. Questions for the committee, for me, for John?
Don't want to go backwards, Jim, but I do want to put this into the record and the recording. So here is the document that's in your packet on food safety inspections and transparency. And to the 2 people that watch this recording on YouTube, I just want to make sure that they know riverstonehealth.org/food survey to fill out the survey, and that folks have access to the QR code to take the survey. And so here's kind of the inspection rating pilot timeline of what we're working through. Working into this summer to launch the Brent voluntary pilot to collect feedback and see if this is actually going to be as helpful as we think it is. So thank you.
Welcome. And one other thing, we did discuss John's employment contract. Remember, we have kept our CEOs under employment contracts, and it will come up for renewal sometime soon. The executive committee would like to renew it and had time to notify Stuart. So as that time approaches, the committee would like to see a renewed and updated contract with John.
I'm not going anywhere.
And the committee would accept comments from anybody.
Yes. Any other comments? And hearing none, a motion to accept the minutes of the executive committee.
So move.
Second.
All in favor?
Aye.
Opposed, same sign. It is approved. The old business to come before the board. Hearing none, We have a Rule 5 variance. We need to schedule. That sinks, isn't it, John?
Yes, hand washing sinks in a body art establishment. And we just need to schedule that hearing in a public meeting. And so we'll schedule that hearing for our next board meeting.
That work? Works for me.
Should do that.
Not that I'm aware of.
Yes.
Yeah. Let's have a motion to.
Second.
All in favor? Opposed, same sign. Megan, 5 minutes ahead of schedule. Educate us about measles.
John, do you want to, did you want to start talking about what's been done, or do you want me to?
Well, yeah, I was going to share some of the materials that we've developed. And have a conversation. You know, we've talked about the state of measles across the country, and some of the things that we are working on preparing. And so we've prepared some public information out there to share with the school systems, along with our Yellowstone Medical Alignment Group, or YMAG, working with the infectious disease physicians, providers up the street of both hospitals, as well as other folks across the healthcare spectrum in this community, to make sure that we educate and update folks enough as possible. We have a meeting scheduled next week with SD2 and Dr. Garcia. Seems we've been dusting off letters and materials more often now on an annual basis with regards to measles or chickenpox or whooping cough or whatever those vaccine preventable diseases might be. We're seeing more and more of them popping up in this community or across the country. And so we have guidance created with the school system so that we can get communications out in the event of any possible exposures that happen in our community and across our schools. So we've been developing some of this publicly facing information, as well as working with DPHHS and the state to create vaccine FAQs, as well as signs and symptom FAQs, as public health is a victim of our own success. We have eradicated illnesses. We have gotten rid of them across this country and throughout the world. And folks don't realize the devastating impact that they can have on their children, on themselves, and on their communities, because we've done such a good job keeping them out of our communities as a result of vaccine science, safe and effective. And so now, as we see vaccination rates wane across the country, these illnesses are reappearing and popping up across our communities. And so we've done such a good job keeping them out of the limelight that now they're coming back. And so we're having to do some re-education, not only with the public, but with medical providers, particularly when you look at our residents coming out of med school, new doctors, new NPs and PAs, who probably haven't seen a measles case in their career or polio case in their career. And so we're doing a lot of clinical re-education. And so that's what we've been up to across the community, just prepping. We've also had several tabletop exercises, simulated incidents and exposures with our hospital partners and other institutions across this community to, prepare and plan for how we're going to act and react should one of these illnesses reach our community. So we're doing the best that we can to make sure everybody's prepared. Everybody knows that we actually do have written plans and written materials in place, checklists and procedures on how to react and respond, who to call, how to isolate and contain individuals who do have an illness, so that we can keep the majority of our population safe. And so those are the materials that have been popping around out there. And I'll turn it over to Megan after taking Coach's question.
Just an observation. The older members of this group can remember how excited we were when the polio vaccines were announced, because we were very aware how bad it was.
Megan.
Yeah, I mean, I think memory is short, and I think most people today did not see the consequences of some of these vaccine preventable illnesses firsthand. And now we're seeing some of those come back. So yeah, everything that John said, I mean, I think we've had, so last year we saw a smaller peak of measles and an outbreak that was largely in Illinois, largely around Chicago. And around that time, both at the state level and the community level, we started to kind of relook at measles, pull out what protocols we would use should measles come into our community. And we had a tabletop, we hosted a tabletop here with some of our partners last year, where we just sort of what would happen if a measles case came through. And then the state just last week did a regional statewide tabletop with a measles case, and they actually had health departments from several different counties all online in a Teams format, and then our community was up at the Mansfield Center, sort of running through again what will we do as a community, and identifying some of the holes that we need to sort of fill in, and there are some follow-up things that we're going to be doing over the next couple of weeks. One of the things, measles, when it initially presents, it really just presents as a common cold, right? You have a cough, you have congestion, you have conjunctivitis, you have fever. I mean, it really looks like every other, thousands of URI symptoms that we see in the pediatric population all the time. And so what we're starting to do is, and the rash doesn't show up until usually around day 4. The rash is pretty characteristic if you know what to look for. But by that time, you've had 4 days of exposing everyone. And so what we are really what we're doing here at RiverStone and other areas across the county are doing this as well, is starting to pull out, like, when someone's coming in with symptoms of fever and URI symptoms, asking the travel questions. Have you traveled? So that we can identify if they're coming from a place where there's a measles outbreak. If they have traveled, or if they have concerns about measles, are you vaccinated? And those families will be handled and triaged differently if there's higher risk for measles, to try and get them out of the ED waiting room, into, we have some rooms that are negative pressure, get them into those rooms, get staff in appropriate PPE, and be able to get the tests done that we need to do and identify the case as soon as possible. So, yeah, lots of education, lots of plans. Hopefully we won't need to use them. But
the turnaround time of the test center thing, Joe?
Yeah, so that's a great question. That's sort of where we're at right now. It kind of depends. What we're working through, so Billings Clinic sends their measles tests to Mayo. You can also go to the state lab. So the state lab and Mayo are sort of the two places that our labs would go to. And that's one of the things that we're sort of working on right now is, do we want the labs to Mayo? Do we want to send all labs to the state? The state doesn't run labs on the weekends usually. Now, if we call them and said we think we have a case of measles, that might change, but those are some of the details that we're working out. But usually 24 to 48 hours is what.
What's turnaround time? What do you think turnaround time on the tests be at the labs, Megan? Any idea?
Yeah, 24 to 48 hours, we're hoping. But again, it depends. So there's so many factors, right?
Yeah.
Like, so if it goes out to Mayo, does it get out? I mean, when does it get on the plane to get to Mayo?
Right.
Right. So if it gets out in the morning, then we'll probably have that result back by the next day. If it doesn't get on the plane until, if it gets ordered later in the afternoon and doesn't get on the plane until the next day, then it's going to be another 24 hours. And we still have that courier issue going to the state lab too.
Yep.
And so, and if it's a Friday, all these things, we're anticipating that this is going to happen on a Friday evening, because that's when these things happen, right? Like, we're going to have a kid walk in who's been at school all week, who has a rash on a Friday at 7 o'clock. And so, there's a lot of variabilities of, what that would look like. And those are some of the things that we're working with our public health department and the Montana DPHHS and the hospitals to figure out what would be the most rapid for testing. We have all the testing supplies. That's the other thing that we're, sort of looking at, is how quickly can we get the testing supplies that we need, and making sure we have all that on hand. And then also starting to think about how would we rapidly deploy vaccination clinics for those people who then have been exposed and want to be vaccinated, because there's a window where unvaccinated or at-risk people can get either immunoglobulin or the vaccine, and we need to be ready to mobilize that as well.
Thanks. The labs could get backed up if you have an outbreak too.
Yeah.
If they're not used to the throughput.
All right.
Haven't been doing this 70 years.
So then if somebody's diagnosed with full cells, is there any value to doing titers on family members or?
On family members? The vaccination is so effective, right? I mean, 97% with 2 vaccines, that's about as effective of a vaccine as we have. And so they're not typically where you might, so there's, children all get the 2 series. People born before 57 are presumed to have had measles and have lifelong immunity. There's a little bit, the adult population typically gets 1 vaccination, is what the current recommendation is. So if you were someone who, was exposed and had only had one vaccine, you could do titers, but you probably would just get an additional vaccine. There's no harm in getting extra vaccinations. And so that's one of the things that we'll also, think about. There's also, so typically the first vaccine you don't give until 12 months. But in an outbreak, or if there are kids or if kids are traveling to infants are traveling to places where there is an outbreak, then you can give that vaccine as young as 6 months. And so, those are sort of some of the other things that we're trying to make sure people are aware of, mainly providers will instruct the public. We don't want to cause, we don't want all people with 6-month-olds coming to their doctors and asking for MMR vaccines right now, because that's not the recommendation. It would only be if we had it in our community or they were traveling.
And if mom is vaccinated and she's breastfeeding, that baby is getting protection through the antibodies in breast milk. So that's why there's some delay there.
When did the measles vaccine, when were they first made available, broadly available?
Gosh, I think it was, I don't know the exact year, but I think it was in the early 60s, I believe. It's when now the first vaccine that was available. So there were two vaccines that came out, and the first vaccine that was available was not as effective as the later vaccines. And so that's where there's part of the, you know, if you're born before 1989, do you need one or two vaccines? Because you might have gotten the earlier, less effective vaccine. But I believe it was in the early 60s.
Speaking on behalf of the people.
I look at that, 1963, my vaccine history.
Speaking on behalf of the people born before 1957, I guess I have a question about that. Presumed to have had measles. Okay, I've never had measles. I'm sure some of my friends did. None of my siblings did. So I know I never did have measles. But is it sort of assumed that I've been exposed enough to?
Yeah, that, I mean, it was so endemic back then that most, you know, yeah, it's presumed immunity. I mean, you can get titers, or you could get you know, there's no harm, you know, you get titers done. There's no harm to getting a booster vaccine.
And I can remember when they used to have measles parties.
Yeah.
Chickenpox.
Yeah, they did that with chickenpox too, yeah.
We've had measles.
Yeah.
I promise you.
Huh?
You have.
Why do you say that?
Because you're so old.
Have you had access to my medical records?
Up to those pieces.
So clinical facing.
Absolutely.
All right.
I'm sorry.
I gotta run till 9 o'clock.
Thanks, Mark.
Thanks, Mark.
See you, Mark.
Yeah.
Any other comments or questions for John or Megan about measles? Yeah.
Am I allowed?
Yes.
Two quick comments. I remember having this conversation at a board meeting about 2 years ago, when there was a minor outbreak of measles. And the only comment that I had at the time, the only comment that I had at the time was that measles scares me. And the reason is a person with full-blown measles, not the subclinical infections we had, Brent, but the virus replicates in cells of your immune system, the cells that you want to protect you against the disease. The virus is killing those cells, which is part of why the disease is beyond subclinical. It is so nasty. That's a term. That's a clinical term. Megan is approving.
Very nice.
And the other thing that it does, when we get vaccinated against various things or exposed to various illnesses, we develop memory responses, so that when we're exposed the second time, we respond much more quickly. Full-blown measles, the virus kills the memory cells. All those memory cells that we developed over the years and from vaccinations, all of those memory cells are wiped out. And so you have to start over again. Measles scares me, and it should scare a lot of people and tell them you should be vaccinated. Okay, and avian influenza, with a couple of key mutations, it could be readily transmissible person to person. There are people that have become infected because of large doses of exposure of the virus. But with a couple of key mutations, it's possible, but not probable. But with those key mutations, avian influenza could trigger an outright epidemic. And there's a very high mortality rate sometimes associated with avian influenza. Enough with the academic stuff. I have absolute 100% confidence in Eric and Megan, and the staff is planning on those possible outcomes. and is making sure that our community is protected with as much information as the people in our community will listen to and believe. Absolute confidence in the two of them. Thank you for the time. to speak. Now I'm done.
It's the key.
Yeah. I think the other message that I think school district 2 wants to kind of get out is that so the incubation period for measles, it can be up to 21 days. And so if you have been exposed to measles, and as we sort of talked about, it's highly infectious. So if you're in a school and you're walking around in the hallways, virtually everyone in that school is considered exposed because it's airborne. So it's very small particles that stay in the air for up to 2 hours after someone has, left that area. And so if you are unimmunized, have not been vaccinated, and you've been exposed to measles, you need to be quarantined for 21 days. If you do not, so if within that window period you go and get your first vaccination or you get immunoglobulin and you don't work in healthcare, then you don't have to be quarantined. But that, so when parents start to think about what that means for their child to be out of school and out of all public activities for 3 weeks, that kind of makes you really think, is that a risk that I really want to take? And so I think that that's one of the messages that school district 2 wants to get out ahead of time, that just recognize if you're choosing the unvaccinated route, if exposed, that's 3 weeks that your kiddo cannot return to school. And so, I think that for some people is also a motivator to rethink the risk benefit ratio of vaccinations.
And we still have a lot of religious exemptions. People are coming in.
We do. Yep. Yeah, I think school district 2 estimated that 95%, is that what they said, John?
I actually can't verify that right here.
But I think that's what we sort of estimate for the community.
So if you have an exposure in a classroom and there are, 30 kids in the classroom and 28 of them have been immunized, but 2 have not, is it the 2 that have not that have to sit out for the 3 weeks, but the others do not?
Right. If you're vaccinated, you're considered protected.
Michael.
I'm sorry.
No, I don't apologize.
Debbie mentioned religious exemptions. There's either 2 or 3, I forget the number, 2 or 3 recognized religions, organized religions in the United States. And nobody's ever heard of them. If I could remember the names, you would have never heard of those religions. There's only 2 or 3 that have an absolute avoidance of immunization. All the others are somewhat optional. So the religious exemption thing is just nonsense.
I disagree with you 2,000% in the state of Montana.
Right.
That's wrong.
In
You have wrong information.
In
It doesn't
Montana,
work that way.
What?
It doesn't work that way.
Well, I mean,
We'll talk later, but it doesn't work that way.
in Montana, it doesn't have to be a proven religious.
In Montana, yeah. Yeah, just part of the nonsense.
It can be a deeper spell.
It's only nonsense if you don't believe.
so we have a lot of, we also have pending legislation right now in Helena, in both Senate bills and House bills, that look through not just religious, but conscious exemptions and how they will play out. So there's a lot changing all the time, particularly at the legislative level while the House and Senate are in session. So we'll continue to watch what bills make it through and how we're able to manage vaccinations in the schools going forward, as well as childcare centers. So lots to watch for at the legislative level locally.
Other comments about vaccines or measles? Hearing none, we have 10 minutes. If anyone, won't do a round table, but does anyone have thoughts they would like to share after today's meeting?
John, do you remember what the last day of the legislature is offhand?
Everything's changed. Okay.
Not soon enough.
Probably late April.
Yeah, it's late April. Yeah, everything's changed with the scheduling issues the Senate's had, and so I can't remember off the top of my head.
I think today's day 59, so you have 31 days left.
31 left? Yeah.
A total of 90.
Yeah, it depends on whether it meets Saturdays or not too sometimes.
You know, with the time we have left, Jim, I will share for everybody our new anniversary marketing messaging. We've reinvigorated a campaign, and that's love to share for folks.
Life in Montana is a journey marked by seasons, change, and the beauty of our wild home. Like snow that forms our rivers, our history shapes who we are today. Your community-based healthcare provider. From immunizations to compassionate care, we keep you and your family healthy at every stage of life, because staying healthy means being ready for whatever comes your way. RiverStone Health, part of our communities for over 50 years.
Good job.
Yeah, I always like those.
Yeah.
Welcome. I'm Kendra Diefenderfer.
Does that get on social?
Yes.
Hey, John.
Yeah.
The legislative calendar has day 90 on May 5th this year,
May 5th. All right. So we're going to May.
as of today. Unless somebody gets excited and does a signed eye like they did last, and or
Yeah.
anyone like they did last.
So
So,
thank y'all.
so not that it makes any difference, but the vaccine for measles is 63, but the MMR came out in 71.
Yeah. No other comments? Thank y'all. I appreciate the conversation. I do just want to say that everybody sitting around this table at all times is always welcome to their own personal opinions and beliefs. But as the publicly facing Board of Health, we have to also take into account everything that happens at our state legislature, all of the rules and regulations that we have to follow. And we have always done the very best job for over 50 years, following those state laws and federal laws to make sure that we're compliant at all times. So thank y'all.
I would like to commend Carol, Michael, and myself for being here on what should be the first 80-degree day of spring instead of fly fishing. So, and with that, we are adjourned.